Good morning, everyone. Thank you all for joining us today for this special National Consumers League event, Count the Copay, Federal Solutions to Ensure Copay Assistance Counts for Patients. My name is Sally Greenberg, and I'm the Executive Director of the National Consumers League, or NCL. Founded in 1899, NCL is the leading nonprofit and advocacy organization dedicated to protecting and promoting social and economic justice for consumers and workers in the United States and abroad. You can learn more about our work and programs at nclnet.org. I'm truly honored to moderate today's event that will explore the critical role that copay assistance plays for patients to access their prescription medications. Our expert panelists are going to explain how health insurance companies are implementing new policies that raise patients' out-of-pocket costs and what Congress can do to ensure that patients can get access to their medications. Before we begin our official program, I want to thank our live and on-demand viewers for joining us for today's event and taking time to understand how we can help protect consumers keep getting access to affordable treatments. So on behalf of NCL, I'd also like to thank all of our guest panelists for taking time out of their busy schedules to participate in today's program and share their perspective. Our presenters today include Colette Koulianos of the National Hemophilia Foundation, Peter Pitts of the Center for Medicine in the Public Interest, and Melody Narain Blackwell of Color of Crohn's and Chronic Illness, Inc. Before we begin, we want to remind everyone why we are here today. Many patients rely on copay assistance to afford and access their prescribed medications and manage their healthcare when no other options exist for their condition. Increasingly, however, health plans are instituting harmful copay accumulator policies that don't count the value of copay assistance towards patients' cost-sharing requirements. It raises their out-of-pocket costs and often puts patients in a bind. Evidence tells us that high patient out-of-cost leads to reduced medication adherence, and nobody wants that. Additionally, we know that the vast majority of patients who depend on copay assistance have no generic options for their treatment. Here's where it gets worse, however, for consumers. Health insurers are also manipulating the essential health benefits provision of the Affordable Care Act at the expense of patients and the critical medications the patients depend on, undermining the consumer protections in this law. And it's wrong. And it's an issue that Congress is taking notice of. HR 5801, or the Help Ensure Lower Patient Copays Act, would protect patients from these practices by requiring health plans to count the value of copay assistance toward patients' cost-sharing requirements. HR 5801 is a bipartisan bill, and it's led by Representatives Donald McEachin of Virginia and Rodney Davis of Illinois. We thank them for their leadership on this issue. And that's ultimately why we are here today. We're here today to discuss policies that are preventing patients from accessing life-saving medications and explore what policymakers can do to protect them. A friendly reminder for our live audience out there before we begin our official program. Everybody on today's webinar is in listen-only mode, but you can use the chat box feature to submit questions to our speakers throughout the program. With that, let's get started. So to kick off our program, I want to welcome Colette Koulianos, the Senior Director of Payer Relations at the National Hemophilia Foundation, or NHF. At NHF, Colette is responsible for the development of the group's healthcare payer education strategies, policies, and programs. Colette has been a leading voice on policies that affect patient copay assistance programs, and NHF is a steering committee member of the All Copays Count Coalition. which is a cohort of groups working to ensure copay assistance counts for patients with hemophilia and other conditions. Colette, thank you for being here with us, and I'll turn things over to you.
Thank you so much, Sally. I appreciate very much your introduction and happy to get started here. Let me get myself in presenter mode. I'm Colette Koulianis, as you heard, Senior Director of Payer Relations for the Hemophilia Foundation, and have unfortunately been all too familiar with these programs since their inception, which we learned of the first plan in late 2016, started or for the 2017 plan year. So let me just skip right past that and start with what is an accumulator, because we know these are called accumulator adjustment programs. But before we start with what an accumulator adjustment program is, let's just first define what an accumulator is. Accumulator refers to the annual running total of money that's paid towards a health plan enrollee's cost-sharing requirements for their deductible, their copay, or their co-insurance that's due until the member reaches his or her max out-of-pocket, or also referred to as MOOP. At the point a health plan enrollee's accumulated expenditures reach the max out-of-pocket limit, then the health plan is responsible for 100% of all covered services throughout the remainder of the plan year. So essentially, your accumulator is how your health plan or your pharmacy benefit manager tracks your what's paid for on your behalf. Now, the whole premise behind what a copay accumulator adjustment program is it's when they change the rules. The health insurance plans or the pharmacy benefit managers change the rules about using and applying copay assistance that's received on behalf of a beneficiary. So when a health plan implements these policies, that essentially it's saying you can use the copay assistance, but it no longer counts to your maximum out-of-pocket cost-sharing requirements. In the past, prior to the beginning of 2017, when copay assistance was used, it did apply towards the member's out-of-pocket. And so, for many, many folks across the country, that was a lifeline for them to be able to access their life-saving treatments. So where the problem comes in for these is just starting with basic healthcare literacy in our country. I mean, most people think they have like at least some basic understanding, but when you actually pose questions to them, like, does your premium count to your max out of pocket? It's surprising how many people think it does, including actually my daughter recently. She was shocked that it didn't count her out of pocket, but your premium is the cost to get your health insurance. What counts to your max out of pocket cost sharing requirement is your deductible if you have one, and then any copays and co-insurance until you hit your max out of pocket. Now, most people don't realize if you have a deductible on your health plan, the deductible must be paid in its entirety before the plan will start paying. Now, some plans have a separate pharmacy deductible from a medical deductible, although those are fewer and far between these days. But that would mean you'd have a separate deductible. Once you hit your deductible for your pharmacy spend, then they begin to pick up their share, and the same on the medical side. But for the most part, most are a combined deductible. When you're choosing your insurance, premiums directly correlate to the out-of-pocket costs, and healthcare consumers, first thing they do when they look for a health plan is look for the lowest cost insurance, so the lowest premium. The lowest premium is going to have the highest out-of-pocket cost. So this is where consumers can truly end up being harmed. So let's look at all the commercial health plans that are on the market, because when we talk about these copay accumulator adjustment programs, these are on commercial health plans. So more than 80% of commercial health plans today have a deductible. And so any deductible at all, 80% of them have. High deductible health plan means that if the deductible is at least $1,400 for an individual, or double that, $2,800 for the family. So if they have a deductible of at least $1,400 for an individual, it would be referred to as a high deductible health plan by IRS definition. 51% of US workers enrolled in 2021 were enrolled in a high deductible health plan. We did a survey along with other patient groups I'll get into later. It showed 55% of patients with chronic health conditions are enrolled in a high deductible health plan. In 2020, a study conducted by eHealth showed that the average individual deductible was $4,364 and $8,439 for family coverage. Now keep in mind, you have to pay the entire deductible before the plan pays the first penny. And this is where this, on top of the policies that are being implemented, creates these huge challenges and burdens for patients. 2022, a high deductible health plan with an HSA. Sorry, I need to grab a drink of water. My apologies. It's very dry in Michigan here. In 2022, high deductible health plan with an HSA can have the max deductible could not be any higher than $7,050 or $14,100 for a family. But if it's a high deductible health plan that doesn't have an HSA attached, the deductible can be all the way up to the max out of pocket for the ACA, which in 2022 is going to be $8,700 or $17,400 for a family. Now think about that. You'd have to pay the full $8,700 before the plan kicks in. So what's important to note is that a member must pay the entire deductible before the first penny is paid by the health plan. So let's go back to these copay accumulators and the fact that they're proliferating in health plans. So they say you can use copay assistance, but it doesn't count to the member's max out of pocket. So it doesn't count to their deductible or their coinsurance. And it's important to note that all copay assistance programs, whether it's manufacturer copay assistance or third-party nonprofit funds, they all are capped annually. They only have a max limit that you can use annually. So if you're on a high deductible health plan with a deductible of $4,000, $5,000, or all the way up to $8,700 as we see for next year, you can max that assistance out in the first 2 months. And then the member is going to be left paying that full deductible again, or the $8,700 upfront before the plan will pay the first penny or before their medications will be dispensed. And that's where the critical challenge comes in. And these programs are very misleading. If 9% of healthcare consumers understand basic healthcare terminology, you can imagine how confusing names like this. Express Scripts calls it their out-of-pocket protection program. So they're calling these copay accumulator programs out-of-pocket protection program. Now, I don't know about you, but to me that sounds like it's something in my best interest. And yet it means that they're protecting somebody else's out-of-pocket, not your own. I don't know how they get away with these names. So the dollars and cents don't add up for healthcare consumers. Today, the median household income in this last year was $67,521. Our individual, I tell you, in 2022 is going up to $8,700, the max out of pocket, and the family $17,400. And we just see the dollars and cents don't add up when you have this kind of median household income with all the other expenses that go on in life: house, kids, car, school, clothes, food, premiums for your health insurance, but also your car insurance, your house insurance. There's no way to be able to, for most Americans, be able to afford these kind of dollars. So we did a survey along National Hemophilia Foundation, Arthritis Foundation, Kidney Fund, Cancer Support Community, and Autoimmune Foundation. And we had it fielded by Public Opinion Strategies. And so some of the findings from this survey that are important to note: more than half of respondents with private coverage, so 55%, reported they had a high deductible health plan, which I mentioned earlier. Out-of-pocket healthcare costs is the biggest problem affecting patients and their families today. More than half of the respondents that had private coverage said that they had a high deductible health plan, which is, I'm sorry, I've already gone over this. Here's the key: patients and caregivers with lower levels of income and those with higher out-of-pocket costs. Because remember, the lower the income you have, the more likely you are to choose a premium that's got a low price tag. But the lower the price tag, the higher the out-of-pocket. There's the direct correlation, as I mentioned. So people who make under $40,000 a year, 69% of them are on a high deductible health plan. Now, there's no possible way they can meet these kind of out-of-pocket responsibilities. And two, most patient and caregiver responders said they're familiar with copay assistance programs, and 2/3 report they or their loved ones are either using them or have used them for their medications. Here's some verbatim responses. I'm going to quickly go through because I want to make sure we get to our other speakers. Half of respondents, or 46%, said they or someone in their household has not been able to afford their out-of-pocket prescriptions in the last year. This was specifically a COVID related, had they been negatively impacted by COVID. So these are folks who said, yes, they've been impacted, and to the level, and everyone has a different story, but their income had been impacted negatively as well. And they were unable to pay their health insurance premiums or their out-of-pocket costs. Nearly all patients and their caregivers, 93%, felt that the federal government should require health insurers and pharmacies to have to apply copay assistance towards a patient out-of-pocket costs. Now, I like to use an analogy, and that is, if I go into a grocery store and somebody's standing in front of me and they're trying to buy their groceries, but they run short on money, and I'm in a hurry, and I say, so how much are you short? And it's, let's just say $12.10. And I say, here, let me pay it. And the person says, no, please, no, really, let me pay it. You pay it forward someday. And so I pay it. And the person gets their groceries. Groceries weren't discounted. The store received the full amount. It just was either from her or from my help, but she got her groceries. Imagine now the cashier saying, oh, that's fine, we'll take this money from her, but we're not counting it to your groceries. You yourself have to pay it. We're not letting you leave the store. I mean, that's essentially what's happening here. So when we asked patients, we weren't surprised to see that, and we asked this by political party, because we had heard, people were going to say that, well, sure, people on one party are going to be more likely to say that the government should help than other. But it wasn't that way. Actually, across political parties, there was a consensus about the fact that the government should require the health plans to count copay assistance towards the members' out-of-pocket cost sharing. Now, we did a survey. This was the patient survey, which was fielded this year. We did a survey last fall ahead of the election of just general population registered voters. They had to be 18 and over registered voters. And in that survey, again, 86% of all voters felt that the government should apply copay assistance. And these weren't people who had a chronic health condition. This is just the general population. Patients and caregivers believe there's negative consequences associated if they don't get help. I'm going to keep running through these. And again, both surveys, whether it was patient-specific survey or to the general population. Now, what have we done? Over the last several years, we have worked together. The All Copays Count Coalition is taking a lead on these copay accumulator adjustment programs. To date, there's 12 states in Puerto Rico that have anti-accumulator legislation. Unfortunately, that legislation only impacts marketplace plans because state does not have authority over self-funded health plans or large group plans. And the majority of commercially insured plans or participants are self-funded plans. On a federal legislation, we're pleased to say that Congressman McEachin and Congressman Davis, one's a Republican, one's a Democrat, have joined together and supporting and putting a stop to these practices. This that you heard introduced at the beginning, HR 5801, the Help Copays Act, was introduced. Today it has 13 sponsors signed on. We have a lot of work to do to grow the sponsor list. But the goal here is to elevate the conversation, and we were hoping to get some administrative fix as opposed to having to go the full legislative route. But we are committed to seeing this through. And I would also like to say thank you to Kim Calder and Rachel Klein, who are both on this call, I see, and they joined me on the steering committee of the All Copays Count. So I will stop there and thank you for your time. Happy to answer any questions later.
Thank you so much, Colette, for a great presentation. The research is really, really so valuable. I'm going to move now to our second speaker, Peter Pitts. Peter is the president and co-founder of the Center for Medicine in the Public Interest. That's a nonprofit medical issues research group which analyzes new innovations in the medical and healthcare sectors. Previously, Peter was a senior fellow at the Pacific Research Institute and also served as the associate commissioner for external relations at the Food and Drug Administration, serving as senior communications and policy advisor to the commissioner. This November, Peter authored a compelling piece in Real Clear Health that explains how the EHB loophole impacts patients and why Congress is on the right track to reintroduce and introduce and hopefully keep the momentum going for HR 5801. So Peter, thank you very much for joining us today.
Thanks, Sally, and good morning, everybody. I think that for starters, it's important to point out that what we're dealing with here is healthcare chutzpah. And what we really need to combat it is health plan literacy. And let me give you an example. 60% of people with employer-based healthcare benefits believe that copay accumulators are a plan benefit, and less than 40% know what out-of-pocket means. So as always, education has to rest at the foundation of what we need to accomplish here. This confusion is augmented and abetted by the misleading nomenclature used by health plans and PBMs, and Colette mentioned some of them. Let me mention my favorite. Sometimes they are referred to as specialty copay card programs. That sounds like a good thing, right? Since it's a program, it must be there to help the consumer, right? Well, actually, not at all. While it may be true that copay assistance programs for some brand name drugs with generic competition do in fact provide an end run around legitimate cost reduction strategies, this is completely untrue when it comes to specialty drugs, which is what I want to talk about today: essential health benefits and the issue of copay accumulators. Now, what does essential even mean? Webster's defines essential as something extremely important and necessary. Now, unfortunately, when it comes to prescription drugs, it means something entirely different. So welcome to the arcane world of the Affordable Care Act and the issue of essential health benefits, or as we call it here, EHB, because everything in healthcare, as you know, has to have a confusing acronym. And the specter of the bottomless deductible. As you've already heard, the sickest and most vulnerable patients in our healthcare system, those with serious, complex, chronic illnesses, are being unfairly targeted by health insurance practices that undermine the benefits of copay assistance for medicines. That's the bottom line. This is an anti-patient program, and it needs to stop. Patients with serious chronic health conditions face multiple barriers to the therapies their physicians have determined are best to treat their conditions. So what's best for the patient, as determined by the patient and the physician, isn't always in line with what the government wants to accomplish, pardon me, or what insurance companies and PBMs want to accomplish relative to their own bottom lines. You have issues such as administrative delays, we've all faced that, prior authorization, which is a great conversation, not for this webinar, but it's right up there with unpatient-friendly things that aid the bottom line of insurance companies, but hurt patient outcomes, and of course, deny access to, deny access to life-saving specialty medicines. But wait, it gets worse. After a patient and their doctor have successfully fought, for example, to overcome the barriers put forward for prior authorization, they face skyrocketing deductibles and steep cost-sharing responsibilities, as Colette has already laid out. And with no other options to afford the medicine they need to stay alive and thrive, many patients turn to copay assistance programs to afford their drugs. Good news? Not so fast. So enter essential health benefits, EHB. Now, essential health benefits are a requirement of the Affordable Care Act to ensure that insurance plans cover a set of 10 categories of services, including prescription drugs. Sounds like a good idea, right? You have to provide care in 10 specific categories, do the right thing. Some plans, however, have applied a loose interpretation by defining some categories of prescription drugs as non-essential, even when they are life-saving or medically necessary for people with serious pre-existing and chronic conditions. When such drugs are deemed non-essential, the patient's insurer will not count any cost sharing towards the patient's deductible and out-of-pocket maximum. So while this is a problem for a wide swath of patients across a compendium of therapeutic conditions, when those conditions require specialty drugs, generally speaking, these are life-threatening problems for the patients, and we have to address it. Now, you'd like to think that we could have an honest discussion among all the folks within the ecosystem here, but we talked about some of the, shall we say, creative names that insurance companies and PBMs are placing on their accumulator programs. Let me read to you what Express Scripts, our nation's largest pharmacy benefit manager, says in their summary of benefits, and I quote directly from their manual, specialty medications are not one of the 10 essential benefits under the Affordable Care Act and are therefore considered non-essential health benefits. Ouch. The very real world of this EHB loophole is this. Patients pay hundreds or even thousands of dollars out of their own pockets for life-saving medicines and never hit their out-of-pocket maximum. That's not a loophole. It's a black hole for too many American patients who have nowhere else to look for help. This has got to change. Consider the impact. An overwhelming share of medicines that are subject to these insurance programs have no generic alternatives available to patients. The EHB loophole disproportionately impacts the most vulnerable patients who rely on certain medicines. Now, let me put something Colette said in context. 69% of those who depend on such assistance make less than $40,000 a year. So the people who can least afford this bottomless copay are the ones who are being disproportionately hurt by the EHB, the Affordable Health Benefits loophole. But help is on the way. As Sally mentioned, as Colette mentioned, the Help Ensure Lower Copays Act is a crucial step forward in this proposition, and especially important relative to specialty medications. This pending legislation clarifies the ACA definition of cost sharing to ensure that payments made by or on behalf of patients count towards their deductibles or their out-of-pocket maximums. The HELP Act closes the EHB loophole, ensuring that cost sharing for any covered item or service within one of these 10 EHB categories, yes, even specialty medications, must be counted towards patients' annual cost sharing limits, must be counted towards a patient's annual cost sharing limits. This is essential. We have to get it done. This piece of legislation would close the loophole, ensure that all patients, whether directly or out of a patient's pocket, help get the patient the assistance that they need. This enhances therapeutic outcomes. And of course, when patients have to continue to pay money out of their own pocket, one of the not wildly outrageous realities is they simply stop taking those medicines. So the cost of non-compliance needs to be built into this proposition. It's real, it's a problem, we have to fix it. Right now, ladies and gentlemen, it's open enrollment time. Patients have to read the small print in what their programs offer. The HELP Act may or may not pass, but the healthcare system helps those who help themselves. And knowledge is power. And this webinar is an important knowledge builder in that proposition. Thank you very much.
Thank you so much, Peter, for that very in-depth presentation. Very clearly stated. I want to move next to our final panelist, Melody Narain Blackwell. Melody is the founder of Color of Crohn's and Chronic Illness, Inc., a nonprofit that works to educate, empower, and advocate for BIPOC folks who are affected by things like irritable bowel syndrome, digestive disorders, and associated chronic illnesses. Melanie has founded and managed many companies and organizations and has been building businesses for over a decade. She also serves as a mentor to business owners and advocates for the chronically ill. Having been diagnosed herself with a chronic illness, Melody deeply understands the challenges the patients face today to access and afford their medications, and how important copay assistance can be for those who are managing a complex disease. Melody, take it away.
Thank you so much, Sally. Thank you. Thank you. It is not lost on any of us that our healthcare system is extremely complex. And with those complexities, a certain literacy level is necessary to navigate the ins and the outs of the system and policies. It also requires a level of health navigation literacy that I'm inclined to believe that laymen and vulnerable populations definitely do not have. I recently reviewed the survey that Colette's organization, the National Hemophilia Foundation, in conjunction with 4 other foundations, conducted on prescriptions and drug affordability during COVID. As I read through some of the findings from the patients and family caregivers, prescriptions drug affordability challenges during COVID-19 survey, it only furthered my confusion as to why copay accumulators, a program used to disparage patients, is even at play. The survey highlighted that people of color are disproportionately affected. They experience more affordability issues. Of those who reported being unable to afford their medications or treatments because their copay assistance ran out, there were 33% people of color. That's a pretty big number. If patients can't afford their medication, this becomes a treatment adherence issue that only widens the gap of inequity and suffering for vulnerable populations. Research shows that most out-of-pocket costs a person has to pay, the more they have to pay, the more likely they will abandon their medication. And this means discontinuing the treatment, and that it threatens the patient's life. Black patients with inflammatory bowel disease are often diagnosed at moderate to severe, already presenting a very difficult level of disease to manage. If a patient stops their treatment due to being unable to afford their biologic and the disease relapses, the medication may not work as well or at all next time. In the cases of biologic therapies, the body may have an immunogenic reaction to the antibodies, leaving the disease unresponsive to the drug. Who's to say that there is a drug now that will even shift the progress of this person's disease into a positive narrative? What will work for this patient, especially when this patient was already on a drug that allowed them to be well? And now the patient is subjected to move to something else that may not work and become a more heavy burden on the ER system. We also know that 90% of branded medications that provide the opportunity for copay assistance do not have generic alternatives. These savings programs are making a way for access to communities and patients that have otherwise not had this opportunity. I personally hear the expressions of coachee community members who can't afford their medications and suffer until they actually get the opportunity to participate in a savings program, and it's life-changing. Copay accumulators unfairly target vulnerable patients who rely on these medications, exposing them to unexpected out-of-pocket costs. A study conducted by the Physicians Foundation in 2019 on how patients experience the healthcare system determined that 42% of patients would be subjected to financial issues if they had to pay $500 or more for their healthcare. We know that these biologics are expensive, well over $500. Vulnerable populations can't carry this burden. Copay assistance programs are extremely valuable to underserved patients, especially those with chronic conditions that rely on multiple medications to manage their illnesses. In order to afford the medicine, they need these. There's no other way. Without these programs, it makes life-saving treatments inaccessible because patients have a higher likelihood of abandoning their treatments due to the financial burden. Have you ever looked up the cost of some of these medications? For fun, I looked up mine, and whoa. I could not imagine having to pay all of this out of pocket. I remember the challenges that I faced when I didn't know that I was diagnosed. And then I was faced with step therapy. And when I finally got to a biologic, I was offered a savings program, which allowed me to pay for the medication, which has now allowed me to be functional. I was not functional. These illnesses, these chronic diseases are debilitating. And for those who are in a space where they can't function, they can't work a 9-to-5, the copay accumulator completely puts them in a space of not being able to manage life. Insurers and PBMs are implementing policies that don't count the value of assistance programs for patients yearly, not their out-of-pockets, not their deductibles, and they're putting more of the burden on the patient. The copay accumulators adjust programs to allow the insurers to double dip. They're making more money and patients are paying more for healthcare. The study from the National Hemophilia Foundation determined that patients' costs are increasing through high deductibles. More than half of the respondents with private health insurance coverage, 55%, report that they or their loved one has a high deductible health plan. Nearly 7 in 10, that's 70% of individuals with an income under $40,000 a year have private coverage and report that they or a loved one have a high deductible health plan that is presenting a high burden on them. People with limited means may be compelled to choose these high deductible plans because the lower monthly premiums fit into their lifestyle and their budget, not at all understanding or realizing the weight of the out-of-pocket costs. Millions of Americans rely on copay assistance, the coupons, the discount cards, vouchers, and other programs to afford prescribed medication. For many, higher out-of-pocket expenses create an unmitigated burden and result in treatment abandonment, which can certainly lead to poorer health outcomes and an increase of overall health burden by accelerating the disease progression. This does not align with health equity, nor does it align with better health care and better health outcomes. Accumulators only benefit the insurers and PBMs, presenting patients with more costs and decreasing and eliminating opportunities to have access to what we need. COCHI is in support of and advocating for Help Copays Act, which is the bill that was introduced in the House of Representatives to protect patients from increased out-of-pocket prescription drug costs. This bill prohibits the use of copay accumulator programs, ensuring that they cannot exclude the value of them. Thank you so much.
Thank you so much, Melody, and to all of our speakers for being here with us today. In the time remaining, we're now going to open up for a discussion with all the panelists. And if any one of our audience members has a question, please submit them in the chat. But I'm going to get things going and throw some questions out for our panelists. Let me start by saying, what can participants on today's call do to engage on the issue of copay assistance and federal activity on copay accumulators? Why don't we start with Colette, since I know you said we have a lot of work to do on that legislative vehicle that we've been talking about. Will you give us and participants some guidance about how we can all be most helpful in pushing some reforms forward?
Thank you so much again. I think the best thing that I could recommend is to get engaged on social media. We have some social media toolkits I'm happy to share with you, and you can send out, Sally, if you'd like, where they can just click to tweet to elevate the conversation, to get congressional attention. Also to reach out to your congressman from your state and your district and ask them to support HR 5801. That's going to be critical. And if you have any examples, whether you yourself or a friend or family member has been impacted negatively by these programs, to share the story. It can be de-identified. We don't need personal information, but just to the point of how it impacted, or that they could no longer get their medication. And, you know, as a result, we ended up going to the emergency room multiple times, et cetera. These are the stories that actually capture the attention of our legislators and hope to get them to react.
Okay, thank you for that, Colette. Let me ask Peter, how do we know if health plans are actually instituting the policies that we discussed? Is there evidence that supports that?
Well, the way to find out whether health plans have these nefarious programs in place is to read the small print. Now, I'm sure all of you out there who have health plans, did you really read that booklet that they sent to you? I certainly haven't, and especially more difficult when it's online and the print is small. And that's not by accident. It's buried in plain sight on purpose. So you have to do your homework. Unfortunately, it falls back down to a lot of personal responsibility. I think to Colette's point, even going beyond personal anecdotes and that's of course incredibly powerful, is to ask the Secretary of Health and Human Services to call for a roundtable. These aren't just data issues; these are CMS issues as well, obviously based on ACA language. The ACA language needs to be cleaned up and clarified. President Biden has said he wants healthcare costs to save consumers money in real time at point of purchase. I think the president should give the opening remarks at the summit. Let state secretaries of health and governors and folks from CMS, come to the table, discuss the problems, and figure out the best solution. And I think that they will very quickly recognize that copay accumulators are not only not a good solution, they are part of the problem.
Thanks for that.
Can I jump in real quick to that? I just want to add one comment to Peter's comment there. I would say that, advice that we could give is, if there's at all any way possible, some people only get a high deductible health plan offering. Their employer will offer 3 varieties of a high deductible health plan, no other choice. In that case, that's what you're stuck with. But if you have a choice, it isn't always in the best interest of a chronic condition patient to be on a high deductible health plan. And we realize the premiums could be higher. But sometimes when you do a total cost analysis and you look at what your cost of premiums are and what you're going to be expected to pay out of pocket, it ends up actually washing, or in some cases can be cheaper to go a different route if you look at both the total expenditures that would go out of pocket for the year. So that would be, I want to make sure to add that recommendation there.
Thank you for that. I want to ask Melody a question, then I want to raise a question and concern that was that appears in the chat. For Melody, since you are working with color of Crohn's and chronic illness in lots of patients, the question that I wanted to raise with you is, how do you talk to members of your group, your coalition, about the language that they should be looking for and avoiding when they're picking a health plan for 2022? And I would invite other panelists as well to join into that. So Melody, you want to take this just in terms of how you advise the folks that are working with you in your organization?
Sure. So a lot of the challenge with COCHI, our community members are facing high bills, and what they have, a lot of them do have ADHPs, high deductible health plans, and we've charged them or encourage them to look at what the burden of your bills have been. And if you had paid this, or if you had paid that for this health plan, how would that have shifted some of this cost that you're now having to explain? One of the biggest challenges that we've seen, not just the bills, is that people don't understand the language around health insurance, period. They don't know the difference between the deductible, the co-insurance, the copay, and we've educated them in that space, not directing them, because I have to be honest, I don't have all the answers to what is the best health insurance plan for them. But there are other organizations that we partner with, like Patient Advocacy Foundation, that we can encourage them to connect with, and they support us when we ask those questions of them. But getting them to understand the language is really the foundation of giving them the education, like Peter said, to shift their mindset. A lot of the wording that's used, like Colette pointed out, is very tricky. It's disingenuous, it's surreptitious, and they're reading it thinking that this is what I'm choosing. Oh, this is an out-of-pocket protection plan, so I'm actually going to get insurance that'll cover whatever I paid for out of pocket, that will prevent me from paying more out of pocket. That's a natural line of thought for what you're being presented with, but that's not it. So a lot of the wording is really how we shift them to get a different understanding, to choose something that's more opportunistic for their health overall.
No, thank you for that.
Can I build on that?
Yeah. I just want to say, in the consumer business, we call that false and deceptive advertising or marketing. So that's got a name, and it's a time-honored practice among businesses to say one thing and mean the absolute other. But Peter, jump right in, please.
No, I think that's right. We need to move away from this Orwellian newspeak that we use in healthcare issues. But people vote with their feet. And for people that have employer-based healthcare and are really being hurt by these types of accumulator programs, they need to go to their HR people and say, hey, what happened here? This wasn't the case last year or 2 years ago. This health plan sucks. I hate this. Find another one. Make it incumbent on the employer to make a change, because employees right now have tremendous leverage. We're living through this great resignation period. Employers want to keep their employees. Employees need to complain if they're getting stabbed in the back by dollars being saved, pennies being saved by employers and health plans, and their health suffers as a consequence. They need to speak up for themselves, and now the leverage exists. They should use it.
Yeah, thank you for that really important point. Let me ask both Colette and Melody, would you advise the people who are part of your organization and patients who are in your orbit to never opt for the high deductible plans, and instead, since they're facing a chronic illness, to go for something that's going to provide them much better coverage? And then the question is, can they even afford the plans with the lower deductibles? So would you two give us your thoughts on that issue?
Colette, you want to go first?
I'm talking and I was on mute. So I absolutely. We do recommend if there's a way for them to avoid a high deductible health plan that they would do it, just inherently because of these issues we've talked about today. As I said moments ago, there are some people who only have high deductible health plan offerings and there's no other option. But if there is an option, they should really do a total cost analysis. Like Melody said, we talk about, like, had you have chose this plan, what would your burden have been? We try to have them look at that while they're in the enrollment period. Yes, this has a lower premium, so it seems more affordable. But by the end of the year, if I have to meet all these out of pocket, and if you have a chronic condition, you're likely to cap out and hit the out of pocket. You will spend X versus had you have paid a higher premium with much lower out of pocket, you would have spent Y. And sometimes it can oftentimes be lower had they have gone that route. But they look for the lowest cost premium because that's how we shop as consumers.
Yeah.
And I would just say, to the one point I want to make on Peter's comment, yes, absolutely. We don't say don't go talk to your employer. It's important. But I think it's important as consumers to be careful, because there are different types of employers. There are employers who truly care about employee retention and benefits. And they do, regardless of it being COVID or the Great Resignation. That's just the kind of companies they are. There's other companies that want a warm body in the role, don't care about their people. And there are oftentimes service industry companies, or some of the big, I don't want to call out any company name, but large box retailers. They don't really have as much of a concern whether an employee's ticked off about the benefit package and how much it costs them. So it's important not to go to your employer and say, this is terrible, this is going to cause me to have to quit, it's a horrible, because those people want you to quit based on these strategies. It's more important to go in and say, because you've done this, you're going to leave, I won't be able to afford my medicine, there's no possible way. So I'm going to be forced, after I get off at night, to go to the emergency room to get my, infusions. And they know the cost of that is much higher than being able to do it at home. So you have to put the burden back on them and tell them what it's going to cost them as well.
Thank you.
I echo everything that Colette said, because that's kind of the approach that we take, because they're really learning a lot. A lot of our community members have had access issues. They're not educated on health insurance and even how to navigate healthcare. So when we're having these conversations with them, the word copay accumulator is like a luxury term. They don't even know that. And they're not even, until we kind of put it in their peripheral, they're like, oh, wait, I did go to the emergency room 5 times and I had to pay $580 each time. But my insurance says that it would be $100 copay, and I haven't gotten there. And I'm like, well, you haven't met your co-insurance, or you haven't, we have to go back and help them understand. This is a huge space of misinterpretation and lack of support to navigate. And that's really what I feel like the issue is, because with chronic disease, it's over and over. You never know. It's up, it's down, it's in, it's out, it's around. I'm experiencing chronic disease now, but you never know where the presentation is going to come. So if you are faced with having the only opportunity for insurance is HDHP, you have to figure out where you can make it work for you. But we don't encourage that space ever because of the unpredictability.
There's another, the Part D model is instructive too, where CMS can help educate consumers by having web-based and phone lines to explain to them the proper types of plans for them to choose.
Yeah, no, thanks, and that's a resource probably a lot of people don't know about. I want to ask Will Hubbard's question. He has raised the issue for our panelists. How should we respond to counter arguments against reform that claim accumulator adjustment programs stop manufacturers from paying patients to use expensive drugs where cheap ones might work just as well? Who wants to jump in on that one?
I do.
Okay.
Okay, because that's been the tried and true argument from day one. These copay accumulator adjustment programs push patients to use a higher cost drug instead of a generic. Well, the fact of the matter is, most of the drugs that are being targeted, well, all the drugs, they're specialty drugs, but most of them have no generic or biosimilar equivalent. And even if there is, for these specialty drugs, a generic, like in the case I know my colleague Kim Calder from MS is on, and they have at least one drug that has a generic alternative. That one costs 80-some thousand, one costs 60-some thousand. Bottom line, they're going to max out their annual out-of-pocket the very first fill of the year. I mean, these drugs are expensive. We're not talking about $5 generic drugs out of, or coupons, if you will, that come out of a Sunday flyer. This is for assistance for high cost drugs, which there is no available option. On the Save On SP, the program that Peter was talking about, where they're using the covered non-essential health benefits by carving out the loophole. Those programs actually, we looked at the Save On SP formulary, and 95% of the drugs on the formulary have no generic or biosimilar equivalent. There's none for hemophilia, and many conditions have no option. So that's just, and finally, sorry, patients don't get access to that assistance until they've gone through the utilization management process. There's not a company I know of on the face of this American soil that doesn't have a utilization management strategies in place when it comes to high cost specialty drugs. So first, the patient has to get prior authorization. They have a preferred drug list, likely, where they can only choose these, you know, the lower of the low cost, whatever they do internally to strategize. Quantity limits, step therapies. Companies put these strategies in place to try to control the costs. After the patient goes through all of those steps and gets approval, then they use the assistance. So that's the answer to that question. Sorry.
Okay. Anyone else, Peter or Melody, do you hear these arguments and say, look, it's just a way for manufacturers to give a green light to patients to use expensive drugs when there are other alternatives? Do you hear that? And what are your responses?
We're not
that's
talking
clearly
Tylenol here. I'm sorry, Peter. I just want to say we're not talking Tylenol and Advil. We're talking about drugs that saves people's lives. You want them to be able to afford life and not be a burden on the healthcare system, not be a burden on the justice system, not be a burden on what do you call it? Welfare. They need these drugs to save their lives so that they're now functional. When I was not well and didn't know that I even had a disease, I couldn't move my hands. I was crippled. I lost my mobility. I lost my hair. I was losing my eyesight. I could not process food. It wasn't until I got to a specific biologic that changed my life for me to be functional again. This is not over-the-counter drugs that you can say, here, go take this, here's this for this. It doesn't work that way. And it's unfair for there to even be this kind of argument when we know that they're specialty drugs and we know that 90+% have no other alternative.
You know, Sally, I think, you know, the way to combat that soundbite that, oh, this whole argument is shenanigans of the pharmaceutical industry to you know, sell more expensive drugs. I would ask these people, first of all, would you be willing to eliminate these types of accumulator programs for drugs that don't have generic alternatives? So put them on the line with that, point one. Point two is that generic drugs aren't identical, they're equivalent, and biosimilar drugs aren't identical, they're biosimilar. You know, doctors prescribe drugs on purpose. You know, one of my sons has epilepsy, and you know, these are called narrow therapeutic index drugs. And switching from a brand to a generic, or from one generic to another generic, have profound therapeutic outcomes impact. And this has to be recognized. You have to do what's best for the patients. Doctors don't write a prescription for a on-brand drug because they're lazy. They're doing it on purpose. So I think the practical matter here is what's best for the patient.
That's a great way to wrap things up. I want to thank our panelists. This has been a really good discussion. Peter, you didn't explain to us what the chutzpah piece was, but I got a couple of other Yiddish words for you, like seichel and surus, that you might add into your next presentation, because we've got a lot of both for patients dealing with this problem of copay accumulators and the essential benefits provisions. So thank you all. Any final comments? I think we've got a minute or two left from our panelists, or anything from our audience.
You know, when we do the right thing for patients, we save money and patients succeed on their therapies. It's a great double play.
Yep. I think that's a great way to bring our discussion to a close, and to be continued. This is a really important issue for patients, especially patients with limited resources. You can see that they pay the highest price, and patients certainly with chronic illnesses. So thank you all. Our expert panelists, thank you, audience, for your attention, for your good questions, and we'll adjourn. Thanks, everyone.